Introduce Dr. April Ehrlich. She's joining us from from Johns Hopkins, which has been a partner for us for many years. Since 2015, we've been working with them, and she holds a bachelor's degree in science from health science from my University of Arizona. Her my doctor of medicine from the same place. She completed her internal medicine residency training at Johns Hopkins, Bayview, and geriatric fellowship at Johns Hopkins. She sits on the Geriatric Society and focuses on the dementia. So we're really happy to have you here today with us, and so privileged because we know a lot of the clients and that we see in this community setting is dealing with dementia along with their caregivers. So I think this is an optimum opportunity to speak to people that are working in this field in that community side, which we know it's so important to link that, marry that clinical side to the community side, and us on the community side to be able to get you back that information in a meaningful way, right? So I would like to introduce you to Dr. Ehrlich, and for her my presentation today. And thank you again so much.
Thank you so much. Thank you for that warm welcome. Can everyone hear me? Awesome. Is it okay if I share my screen actually? Because I have a setup here. Is that okay with you guys just for a few minutes? All right. Oh, it looks like it's disabled. It looks like screen sharing is disabled. No worries.
You should be able to share. You able to?
No.
Well, now that I'm not sure because
That's okay. Let's see.
Normally it works, but
Yeah, it seems like whoever set up the meeting disabled screen sharing, so you would have to go into kind of your to allow people to share.
let's see if that works.
Let me see. Yeah. Yes, it does. All right. Hello, everyone. Can you guys see my presentation? Okay, lovely. Well, my name's Dr. Ehrlich. Thank you guys for that welcome. My focus is on delirium, cognitive frailty, dementias. I focus a little bit more on the inpatient side, but I am happy to talk with you guys about ways we can, address dementia in the community, when to maybe get specialty involvement. But I will say for the vast majority of dementias, this is going to be community care. And so, 9 times out of 10, these folks don't necessarily need to come to a big center and wait on those, God forbid, in 1-year waiting lists to get into our memory centers. And so I kind of wanted to go through some things to empower and also give some helpful tidbits for how to work with caregivers to handle dementia. So first I want to start out with what is dementia, because I feel like sometimes we overlook this. I think caregivers and patients especially get really worried. Like, I'm having memory problems. Do I have dementia? Do I not have dementia? And what I want to highlight here is definitely cognitive or behavioral symptoms is the hallmark, right? So when we're talking about memory, someone says, I'm having trouble with my memory, or, maybe my partner is having some behavioral symptoms. But when we say it's dementia is when those problems are now interfering with your ability to perform tasks. So several folks, as we get older, I don't know where my keys are. I don't know where my keys are half the time, or I forgot someone's name, or, some of these little slips that we might see, which aren't necessarily normal, but we might be talking about mild cognitive impairments over time. But what we're talking about with dementia are those people that where the memory problems are starting to interfere with life. So I can't pay my bills. I can't go to the grocery store on my own, right? Those are the things where we really start to worry about, okay, is there enough problem here where we would call this a dementia? It does need to be a change from prior. So we don't want to be calling, let's say someone had a learning disability. We don't want to say that's dementia, right? That's not really fair. It's not due to delirium or psychotic disorders, right? So we don't want to confuse any sort of psychiatric condition with dementia, and we don't want to confuse delirium. And that's a term we don't use that often in the community, but this is when people all of a sudden are very confused out of nowhere. And usually those people are sick, right? So those are the people who, maybe their heart failure is exacerbated, maybe they have an infection, and all of a sudden they're very confused. But that's not dementia, right? Because usually if you treat whatever is making them sick, the confusion goes away. And then lastly, we usually say the impairment involves two domains, right? So whether it's reasoning, visual, spatial, which I'll get into a little bit with screening, but so you really want to, those people we're worried about is when they have these symptoms and it's interfering with their life. And so just, this is just a breakdown of types of dementia. Dementia is an umbrella term. So sometimes people say, well, what type of dementia do I have? Oops, I don't know if you guys can see my, pointer. Can you see it? The vast majority of everyone's going to fall in here. And this is Alzheimer's, right? Over 30% of dementia. This is vascular dementia. So this is people who have had, heart attacks in the past, strokes, things like that. And this leads to a dementia. And then actually unfortunately, autopsy studies nowadays, we're seeing most people are both. Most people is what we call a mixed dementia, where it's Alzheimer's and vascular. And these people are definitely very manageable in the outpatient setting with a lot of caregiver support. These people, it gets tricky, right? They're rare, but the medications are different, the treatments are different, and the behaviors are wildly different. So I'm going to give you some tips on how to maybe catch this and refer when appropriate. But we really want to focus on this because most of the people are going to be vascular and Alzheimer's, and there's a lot we can do to help them with their quality of life in the community. And so this is kind of where I would empower folks in the community. If you're trying to figure out, and I'm going to, have another slide where it's less medical, but if you see people in a clinic or even in a home visit, when you're trying to figure out, okay, are we worried about a dementia? We really focus on onset and timing, whether they have some other medical or neurologic condition, their age, their culture, their education, right? Because folks, we have a lot of people that are older now in their 90s who might have only gone through, grade school, right? So it's not as fair to use the same testing on them when we're talking about whether there's a dementia. Psychiatric symptoms, hearing and vision is huge. So we know now that not being able to hear drastically increases your rates of dementia. So even if you have folks who are younger, 50s, 60s, and they have hearing problems, we really need to be pushing those over-the-counter hearing aids because people who are not hearing are ending up with dementia at higher and higher rates. Substance use, and then this is the functional history. So can you clean your house? Can you fold your clothes? Can you, do these things that get you through a typical day, right? The mental statics exam, I'm going to focus on the MMSE because it's the easiest screen you can do. It takes about 3 minutes, right, to give you an idea of where someone is. Physical exams, if you're more in a clinical role, definitely a comprehensive cognitive and neurologic exams. And these are some basic labs I usually do for almost anyone if they haven't had them before, if they come to me for a complaint of memory problems, because some of this can masquerade. So if someone has high cholesterol, I'll worry about vascular dementia, but if someone's thyroid is off, the cognitive changes might just be thyroid, right? If someone's got diabetes, I'm worried a little bit more about vascular. B12 deficiency can make people very confused, right? It's rare, but it happens. So these are things we usually try to take a look at. But this is more practical, right? When you're out in the community, what should you be worried about and what things should you watch for? So some of these are just kind of what Dr. Yassar, one of the head dementia folks here, talks about, the head turn sign. So that's when you say, did you do that thing yesterday? And the person head turns to their partner, right? And then, I usually try to tell the partners, no, you're not answering for them. But if you see someone constantly, like when you're asking them and they look over at their caregiver, that's a concern where I would say, maybe there's something going on. Non-specific or vague answers, irritability when you're talking to someone, right? Sometimes when people think your visit is a social visit, so let's say you go into the home and you're going to caregive or help out, and you go, how have you been feeling lately? And they go, oh, how have you been? How are your kids? And they start having this conversation, and you're like, okay, if there's turning this into a super social situation, excuses for maybe why they don't do things anymore. So a classic one is, do you do the bills? Well, no, I've been tired. My daughter does that now. That's not normal, right? Almost every time I hear that is because something has gotten in the way of the executive math skills, right? And so resentment to questions. So, oh, of course I know that answer, but I'm not going to tell you because I don't want to, right? Because I can be defensive if you're telling me I have a memory problem. And so these are things we kind of watch for where we go, there might be something going on. This is just what a basic screening form looks like. The mini mental status exam is a great one because it has all those things where we're talking about, right? So we have visual spatial, we have language, and these are easy things. I often go like, what is this called, right? And, a pen, recall. So this is very, very easy, and it helps you get an idea of if someone's having impairments. And if you look down here, there's a scoring system, right? And so 18 to 23 is where we're saying, it's not normal, right? It is a cognitive impairment. But if you're less than 18, I would really worry about if it's an actual dementia, and if you need to check and see if this is inhibiting their ability to perform daily tasks. So when to refer, things I would say that I would, if you're in the home, if you're caregiving, if you see any of this, I would have them see a specialist. So if it's early onset, I'd say anyone under 60, we really want to see those folks because there's something going on. Rapid progression is usually not normal dementia. So if someone's, progressed over a month versus, a couple of years, those people, there's usually other things going on. Psychiatric and significant behaviors. We'll talk about medicines for some of you folks in a second. Motor symptoms and new urinary incontinence. So not, things that have progressed over time. Weakness, tremors, Parkinsonism, right? So walking with that shuffling gait, no arm swing, that pill rolling tremor. Those are things where, it could be a neurologic condition and not necessarily a typical dementia. And so those are the people we like to see early. So if you see any of that, that might be a little red flag to get others involved. But here's where I want to focus most of our time. And I'm actually just going to talk about this for 1 minute so that we can have a brief questions, and I can give you some examples. But the vast majority of treatments or how we handle dementia is absolutely going to be lifestyle, right? And so, controlling underlying disease, but it's going to be exercise, socialization. So, being home, stuck in your home and socially isolated will make it much worse. Healthy eating, stress reduction, sleep hygiene, treating vision and hearing. These are the things that make drastic improvements in someone's quality of life and how their dementia functions. So those lifestyle, caregiver education, especially with dementias, we're talking about structure, routines, using your imagination to change the way the day goes, to make things a little bit more dementia friendly, safety, caregiver support. If a caregiver burns out, it's game over, right? If a caregiver burns out, nothing is going to work. And so support groups, sleep, maintaining a little bit of a sense of humor, which I work on with my caregivers, which I'll talk a little bit about. And then obviously there's methods of assistance. So once someone's, having a lot of challenges, we do have a lot of programs in Baltimore, home-based primary care, PACE programs, adult day centers, right? There's a lot there, and I'll give you the links to those. I'm going to do a brief note on medications for anyone who is a prescriber. And for anyone who hears a patient say like, you know, my grandmother has dementia and she's always like, can't you just give me something to make my brain work? The answer is no, right? There is not a drug in existence on the market today that slows down the progression of dementia. Right? That was a big marketing scheme when these drugs first came out. Nothing slows down dementia, right? We don't have a single drug that blocks the pathway that's creating dementia. We have drugs that kind of reduce symptoms, right? So that's, you know, these classic donepezils. But I want to tell you guys, it only results in mild clinical improvement, right? So when I showed you those testings, on average, people do 2 points better. What does 2 points mean to someone's quality of life? So I would say they don't necessarily always improve people to a degree where it's going to matter or make a person feel better. And they do not improve your ability to function. There's been no study ever on these drugs saying people function better. And they come with side effects. So insomnia and bradycardia are my two that I worry about the most. And if there's no improvement within 12 to 20 weeks, which has been the length of every study known, take it off. Right? If you're giving someone a drug that has side effects and there's no improvement, just take it away, right? People end up on these for years with no improvement and they're still worsening. There's no reason to have the side effect if it's not working. SSRIs can be beneficial if you have agitation or depression and dementia. Avoid antipsychotics. So there's actually an increase in death for antipsychotics and dementia. So we use them, we do, when they are absolutely needed. And that's with a risk-benefit discussion with partners, right? So you know, just we need to be a little bit mindful of that. You know, if anyone's interested in clinical trials, they're always welcome to come here. And then a note to people who do prescribe about the newer drugs on the market. If you're getting patients going like, oh, there's this new injection and it's done great and I really want it and no one will give it to me. We personally, so we don't give it here. And the reason why is it does not improve clinical outcomes. It made people's brains look like it had less amyloid, that's it. And it causes brain swelling as a side effect. It is a dangerous drug, right? So it's fine for research, but I wouldn't, you know, I would just always, you know, remind patients that unfortunately, as much as we want to believe there's that magic cure out there, it's not there yet. So the focus really needs to be caregiver support, caregiver support, caregiver support, right? As we do the research to figure it out. These are my two favorite books. I just want to throw these out there. The one on the left is really, really good for when you're trying to learn how to deal with a specific behavior. I love that book. And then 36-Hour Day is great for families who have a person with dementia. And so these are some resources. I'm just going to point to one. This community resource finder is my favorite tool in the world. So if you have a person with dementia and they really want a daycare program, you click on there, type in your zip code, put in dementia community care, you know, daycare, and then all of a sudden they pop up in your area, like with a certain mile radius. It's a fabulous, fabulous community resource finder. And so I just want to stop here to allow people to ask questions. And I'm just going to give you one example from this book because I love it, right? So when I said I really do love this book. So it's really more of a workbook. So here we can open up to, let's say, general, you know, tips for activities. So let's say my patient or my family member is bored, and so then it leads to agitation and repetitive questions, and you're just like, what can I do? It has these great activities. So one of the ones I use often, but it's saying like, how about sorting activities? Why don't we sort beads by color? Why don't we sit down and play, you know, sort the cards by number? And in fact, in the hospital, often what works well with me is when people are really, really agitated and just so bored, I honestly grab a stack of towels from the linen closet and I go, why don't you help me fold these? And then, you know, people are, you know, can really at least get involved in an activity. And then here, you know, strategies for preventing agitation. So a lot of the things like if someone doesn't hear you, don't say the same thing again twice, rephrase it, right? If someone is agitated, we usually, the best advice I can give to a caregiver is sometimes you have to learn to let it go, right? We're not going to argue about whether or not you might be seeing something. Let's say someone sees, I had a gentleman with a Lewy body dementia who kept seeing animals, right? It doesn't help for me to say there's not a rabbit in the corner, right? They're going to get mad. They're going to start yelling. We're going to go round and round and round. And then I'm going to get frustrated and burn out. But what if I said, oh, it's a nice rabbit. It'll go away later. right? And then there's no argument. It's okay. We can breathe and we can move on, right? So those are kind of some examples of how we can really help our caregivers. And that workbook just has so many. So I'm going to pause. I know we only have about 5 more minutes for me, but if anyone has any questions for me, feel free. And, you know, we're happy to support you guys, but I definitely, you know, caregiver support and lifestyle modification is going to be the mainstay right now. And I want to empower you guys that anyone can do it.
Thank you so much. And I would like to, if we could take down the slides so we can see everyone again and so that we can ask anyone in the group that would like to ask Dr. Ehrlich a question would be wonderful. Is there anybody else? You can take yourself off of mute, or you can put your mic question in the chat.
Yeah, Kate, I see your hand.
Hi. So it just so happened I have some experience today with a demented senior. In where I am, we are a community clinic, but we do have an adult daycare operated downstairs. And I just talked to this demented senior, and I cannot agree more. I mean, we have to figure out what's the need. So for this senior, for a long time, people just think that his brain is not functioning and all that. But then later on, I think it might be just a hearing problem. And then I bought him some, I suggest the family to buy something from Amazon, the hearing device. It worked magically. He was able to just respond to me perfectly. It took some time, but he can produce the right answer. So I just want to echo more. Let's try to troubleshoot around, not just go straight to the brain functioning part.
Exactly. I can't agree more. I mean, those pocket talkers work wonders.
Yes. Thank you.
Is there one more question before we head to the next the presentation that anybody would like to ask?
Shay, did you have a question?
Yeah, sure. So I'm new in my role with ESA HEC, the Area Health Education Center, and just the information you provided was very insightful. So you had mentioned there's like no medicine to cure dementia. Is that correct? Like no medicine at all?
Yeah, I wish I had better news for you there, Shay. So we have medicines, all the medicines on the market are for symptoms, right? Now, if we want to talk about medicines that actually might affect less progression of a pathology, really the only one I can think of, and remember my talk is really focusing on Alzheimer's and vascular dementia, because that's going to be what you see most often, is going to be, for people who need it, that had strokes, statin therapy to lower their cholesterol so that hopefully they have less plaque buildup in their brain. But by far and away, the meds you see people on are symptom medicine. So, if I give you this, maybe you're a little less agitated. Maybe if I give you this, you're a little bit more awake. Maybe you are slightly, so we assume that awakeness with these medicines make them maybe slightly more alert, and maybe they seem a little better, but none of it stops the pathology or what's going on in the brain that's damaging the brain. There's not a drug out there today that stops that. They're trying to with these new medicines, these fancy ones you hear about that are $80,000 an injection, and why can't anyone get them? Well, the reason why is because they did decrease some of what we were seeing in the brain on MRIs, but they didn't make people any less, they were still having memory problems and they had terrible side effects, which, as a side note, for those of us involved in research, has made us think that the entire paradigm where we thought what caused Alzheimer's is completely out the window, right? Because we got the amyloids to go away and nothing got better and the brain swelled. So, right. So now the question is, have we been wrong for 20 years, right? So the research is really, really vamping up, but unfortunately, I don't have a single drug that cures dementia.
Thank you so much, Dr. Ehrlich, for today and spending your early afternoon with us when I know you're probably very busy. So thank you again. Well, I guess the next step here is, now that we've heard from Dr. Ehrlich, is to bring on Charlene Carr, who is the Senior Care Program Director of the National Family Caregivers and Support Program, a part of the State Department on Aging. She joined the department in January 22. And she is responsible for the information, guidance, and support to all of our my local area agencies on aging. So we're very happy to have her here today. And Charlene joins us today by the way of the Department of Human Services, where she was the budget supervisor of my social services. So we're very lucky to have her, and we're going to turn this presentation now over to her. Thank you again, Dr. Ehrlich, and we hope our paths cross with you again. Bye-bye. Okay, Charlene. And we would be happy for my Dr. Ehrlich to stay on for the end in case there's any more.
Just realized I was muted. I apologize. Good afternoon, and thank you all for having me.
Thank you for joining us.
Today, I'm going to provide some information on the National Family Caregivers Program. Basically, the purpose of the program is to provide information, resources, and services to family caregivers as they help to maintain their loved one being able to stay in the home and in the community, and to provide comprehensive services to formal and informal caregivers, and grandparent family caregivers as well. And they also want to help to maintain those individuals within their communities and within their homes. Now, the caregivers program is also married somewhat to the senior care program. I'm not sure if you all are aware of either program, but senior care is a program that basically caters to the recipient, and caregivers caters to the individual that's taking care of the one that's needing care. And a few services and supports are information, of course, access assistance. We offer counseling, training, education, and respite services as well, and supplemental services. And with the supplemental services, but basically that is, tools to help them to be able to deal with incontinence and things like that. But those, first, let me tell you who's eligible, the individuals who are eligible for the program. Maryland caregivers who are 60 plus, Marylanders who are also 60 years of age and older, their relatives, aunts, uncles, neighbors, friends. You can have an informal or formal caregiver, meaning if you've met someone and they said, well, you know what, I used to be a nurse, but now I have some extra time and I don't mind being a caregiver for you. So it doesn't necessarily have to just be someone in the family. Caregivers of children who are, children who are 18 years and younger. Grandparents also, other older adults who are between 55 and 59. And those two can also be formal and informal caregivers. Now, the respite is also one of the programs that we have, one of the services that we offer. And the respite services include care recipients who are 60 plus, and they have access to adult daycare, in-home support, senior plus centers, and now those are virtual and online, virtual and in person. They have day and extended periods of time. They may have to, if someone needs to go overnight for a particular service, they have someone who they can help to refer you to, so that you'll be able to get someone to come and stay with that, with that person receiving care overnight. Excuse me for 1 second. Thank you. Also, those that are disabled, individuals 59 and younger, and children 18 and younger who have disabilities. They have access to day camp, They have access to camp for overnight also, daycare before and after programs. Say for instance, if someone needed, they just wanted a break to go out and get their hair done or get their nails done, they have services that would come in and provide respite for that as well. And that too can be someone who's formal or informal, a family member or just someone who wants to provide care with that particular person. Some of the supplemental services that I was touching on before are nutritional supplements for food, say for Ensure, things like that to help to maintain their care, medication, prescription, and, and over-the-counter. Incontinence supplies that I was speaking of before, if they need diapers, if they need the chucks. I just learned that word. And that's like the blue, it's like a blue bedding that goes on the bed to help prevent the bed from getting wet if they were to have an accident. We also do minor home repairs, anything that will help the recipient and the caregiver actually to be able to get access to each other and to be able to come and go as they please to help maintain their independence. We have specialty equipment, which is offered through DME, which is the durable medical equipment that the state offers. And that program is a free program. They would just need to contact their local area agency on aging and let them know that they're in need of, say, a rollator or a walker, or that we have some individuals who have trouble getting in and out of the bed. They actually have the equipment to be able to transport that person from the bed to a chair. And this equipment is free. They have hospital beds, again, free. And they're located in Prince George's County. We had a meeting there one day and we went to the warehouse. The warehouse was huge and it was wall-to-wall equipment. There is nothing that you could probably think of that a caregiver or a care recipient would need that they did not have. They had wheelchairs for babies, for the little ones, and the wheelchairs for adults being able to, even those that they can push themselves. They had the rollator ones where they push a button and they accommodated it to that particular individual. So again, that's through the durable medical equipment through the state of Maryland. They also offer health improvement classes and services if you want to take a class in exercising and things like that. And lastly is transportation. You need a ride to the doctor's office, or if you need to go to the market, you can get round trip transportation that'll be able to help to service that particular need. And basically, this is offered throughout the entire state of Maryland. Every county jurisdiction has an area agency on aging that would be able to assist with these services and providing resources where you'll be able to get additional services. And that's my spiel, the quick and dirty version. Are there any questions?
Thank you so much. Is there any, because we know we've heard Dr. Ehrlich and now we've heard the expertise of bringing on those resources by Charlene. So is there any questions whatsoever that anybody would like to ask?
Leanne, can you hear me?
Yes.
Sorry. I just wanted to ask or to comment on Dr. Ehrlich's presentation, which is certainly informative. And hopefully one day we'll have much more information about the brain and how it really works, right?
Mm-hmm.
One of the things I think that's so important for caregivers, family members or otherwise, I know that a lot of times when people who have dementia sometimes gets that we have a good history of what they used to do, because I know that we've had a lot of in the past and some other places that I've worked, basically when they looked at some of the patients that got very irritable at certain times of the day or other times that they couldn't figure out why that was, it was like at 3 o'clock this happened. And then when they would kind of investigate what happened, they were like, well, at 3 o'clock every day, this person was the person that went to the bus stop and was a crossing guard or something to that effect. So I think it's so important that we do have a good history of the people that we're serving so that we get their little innuendos and can read the signs if we can.
Yeah, exactly, Paula. I agree. I wish we understood the brain more. But I think tying that to Dr. Carr's presentation, I mean, this really is the main, I tell my patients time and time again in the memory, I work in the memory clinic as well here at Johns Hopkins, is, you know, medicine is this little itty bitty proportion of dementia care. The vast majority of where we see the bang for your buck and improvements is going to be learning to modify, learning to let go, and the caregiver support, right? If you can get someone with all these things she was saying, where they're not trying to be in survival mode 24/7 and can have some joy again, I mean, people's quality of life goes up for the patients and the caregivers. I mean, that's really where efforts focus right now.
And this is Sue Lockemeyer, and I have to share, recently I saw an amazing video. It was Glenn Campbell, who did have dementia, and he certainly was well into the dementia at the time. He played his guitar. You know, he talked, you're nodding, you've seen it, I can tell. He talked about, you know, the Lone Ranger and all of that, and he played it with an orchestra. And at one point, he puts the guitar on his head and still plays it. Just, you know, people with dementia have special things that they did or accomplished or care about, and we often forget.
For sure. Thank you, Sue, for sharing your story. The one thing I would like to ask Dr. Ehrlich is, as you're seeing your patients come in, what do you see is their greatest need that we can work on this community side? What do you see as the biggest needs?
That's a great question. I would say definitely the biggest needs. When I talk about why do people end up in the memory clinic versus like a general geriatrics or internal medicine clinic, it's really because they haven't tapped into the resources and don't know they exist. That's why, right? I mean, it is not hard to prescribe donepezil and take it away in 12 weeks if it didn't work, right? It's maybe a little harder to explain to people interested in the newest and greatest in drugs why they're not working. But the medical aspects of dementia care, unfortunately, in today's day and age, is not well thought out, and it doesn't. That's not where we spend all our time. Where we spend all our time is connecting to resources, educating family members, educating about ways to handle different behaviors. And so I firmly believe that this can be handled in the community if it's Alzheimer's or vascular dementia, which is over half of all dementias. And it all comes down to knowing these things that Dr. Carr was talking about, because if you have an arsenal in your clinic, and that's what we have an arsenal of, you know, books I can give people. We have an arsenal, you know, we get grants for books. We have an arsenal of like the list of these caregiver support websites and where to find them, and the ones in Maryland. Where are the driving programs? Where are, you know, these home-based programs? And when you have all of that, when you go and you put it all together, you really don't need us most of the time, right? Like, I don't think we're any better than anyone else out there. It all comes down to access and knowledge of the resources that already exist.
Thank you so much. And I guess my next tag on to that is, when a patient's caregiver is coming in with them, what is their major concern and ask?
So when it's new, the major concern is fix it, right? And there's usually a lot of tears. And I've been there, right? My grandmother has dementia, my mother's her caregiver. So there's usually a lot of tears, a lot of counseling about, you know, ways we can help support you, but I'm not going to be able to cure your mom or dad or loved one. But what I can do is support you through it and make it easier, right? And a lot of it, the biggest ask is usually behaviors. Sometimes involves medicine, most of the time doesn't. And a lot of it comes down to reframing. So I'll give you examples from my own grandmother. So wandering, she loves to wander the halls at her assisted living facility, and it's locked in. She can't get out. So my first question when they brought it up was, so what? Let her wander all day. And everyone's like, well, wait, why would we, what? And I was like, is she harming anyone? Right? And then she's happy because she's wandering all day, and everyone else is happy because it doesn't matter, right? And so it's really like learning to let those things go. At home, it happens too. I've had patients call me and go, Mom packed her bag and she's headed home. God knows where home is, right? It's usually the old house when they were 7, right? And then you go, oh, well, did you remind them they're going tomorrow, right? And then there's not a fight over, you live with me, you don't have that home, you're 80 years old, right? It's more like, oh yeah, we're doing that tomorrow, right? And teaching people that like, it's not lying, it's using creative solutions to let things go so that you are happy, they are happy, we're not fighting, right? And, you know, using these resources for your DME and stuff. And those are the big things, is because I think family members and caregivers oftentimes feel responsible and like they have to explain themselves over and over. And I try to teach people that like the brain is now abnormal. So it doesn't matter how many times you explain logic, it's not going to work. So why don't you let's just focus on quality of life. And, you know, if the easiest explanation is it's tomorrow and then tomorrow it's tomorrow again, that's okay.
Yeah, it's just like when I ran the support group, I would actually tell them, because they would always say, well, you stole my wallet, you stole my purse. I would tell them, why don't you just keep 3 different wallets in the house and just keep some cash in each one of them? And then if you can't find it, just pull another one out. They won't know the difference, and there's no need to argue about that.
And those are the creative solutions I talk about that especially are in these books that just make, it's amazing how life-changing it is, especially if you have caregiver support, maybe a support group, how life-changing it is when you learn how to let it go and some of these sneaky tricks, right? Like, you know, where is dad? You don't want to tell them dad is dead, right? But if you say like, I don't know, where do you think dad is? Oh, well, dad's probably here. Oh, you're probably right. Right? Then everyone's happy.
I have a question, and this is for Charlene. You mentioned about your National Family Caregiver Support Program. Like, do you have to be financially eligible? Is it based on, you know, someone that doesn't have as much money as opposed to, you know, maybe a family that does? And the second part of my question is, you mentioned area agencies on aging. Like, where would I find that for my community? So is there a particular place that I can look to be able to find who to contact where I live? You're on mute.
Okay, what jurisdiction are you in?
I am down on the Eastern Shore part.
Okay, well, on the Eastern Shore, we have, depending on how far down you are, we have MAC, as you're familiar with.
Right. So is there other areas of the state that have?
Every jurisdiction has one. If you want, I can give you the number to the one that's located in your area.
So if there was a particular, so for anybody who's on the call here today, how would they be able to refer a client in their area?
What they can do is go to our website, because we have a listing on the website of all of the jurisdictions within the Maryland Department of Aging. And for, yes, there is I think there's a $20,000 eligibility for caregivers. They have to, they cannot have anything excessive of $20,000. They would have to spend down if there were more for eligibility.
Okay, thank you.
Leslie,
Another place they could go is the elder care locator. If you have someone that may not be in like Virginia or Delaware or somewhere where you might know, you can just type in the zip code and it would give you the exact location to go if you go into the elder care locator.
Or 211. We could always call
either one of
211.
those you can use.
Kathy Walker has that information, Leslie. Call Kathy.
Okay.
I have a question regarding transportation. Is that for all eligible people 60 and over from the area
They-
of aging?
If they're participating in the caregiver program.
Okay. Okay, thank you.
You're welcome.
So is there anything else we would like to ask Charlene or my Dr. Ehrlich today before we might conclude this meeting?
I just wanted to also add, I think with Dr. Ehrlich's prior, just discussion, that I think it's important for the caregivers, particularly if they're relatives, and they're, not extant to the family, that our perception of what people are telling us because we are emotionally involved is much different than people that may not know them. Because when people say, I just want to, I think Dr. Ehrlich was saying, where's home? I just want to go home. I've asked people that before. And I said, where, with the family members with them, like, where is home? And they said, I really don't know where that is. But they still have that emotional attachment. And I think it's so hard for the family members because they're guilty, they maybe can't take care of them at home. And I think we need to also support the caregivers so much because they are so entwined in the emotional component of, caring for people that they can no longer possibly care for. It's very difficult.
And that's so true. And as best we can, I mean, there are strategies, right? Diet, exercise, socialization, making sure they get out and are doing things, but which really help kind of reduce the memory problems you're seeing. But as much as we can, really eliminating that factor of guilt. So I'll give you guys a 30-second example. My grandmother, before we moved her into assisted living, started wandering to find alcohol. And we had to call the cops twice to find her, right? And I am a physician and I treat dementia, right? And that's okay. Like when I talked about, we're trying to focus on risk mitigation. I'm never going to be able to get rid of the risk in the world, right? And so telling my mom was like, APS is going to come arrest me. I was like, first of all, they don't arrest people, right? APS is meant to help people. They get involved when you need more resources and they can help give you resources. It is not, they don't come out with cuffs and arrest people, right? Unless you're talking about an abuse situation. And so I was like, okay, clearly she can't live alone anymore. Let's work on that. We got her somewhere. It took some time because she was really against it. And so there was some risk there. She was still at home, but she was wandering somewhat, but that's okay, right? We don't need to guilt trip people. Like life is messy and life can be messy and we don't need to make people seem like they're failing, right? It's okay.
Thank you. We have one more question. So does the next person want to ask? Amanda?
I just wanted to piggyback on what I've heard everybody saying in this meeting today and just share that Maryland Access Point is a really great opportunity to connect to a lot of the services and supports that Charlene was talking about, that Leanne was talking about. Maryland Access Point is the one-stop shop for information assistance and referral in the state of Maryland for older adults, those living with disabilities, and their family caregivers. So if you are looking for programs and services in your community specifically that can address caregiver needs, that can help find resources available to support you as a caregiver, support your clients in finding safe housing, whatever it might be, they really are a wonderful resource. They can help people connect with some of those things that April was just talking about, exercise, good health and nutrition. There are lots and lots of programs available through area agencies on aging, and the quickest and easiest way to contact AAAs and get access to many of those services and supports and really look at a comprehensive service delivery of long-term services and needs is through Maryland Access Point. To get access to Maryland Access Point so that you don't have to remember anything else, you can just call 211 and Maryland Access Points across the state work very closely together. They make referrals to our AAAs and our MAP offices. As a matter of fact, the 800 number, which is our MAP link number, our statewide MAP number, which I'll put in the chat, is answered by 211. So if you don't remember anything else, remember 211, because 211 can help you connect to a MAP office and thereby connect to all of the community resources and supports that are available in your community.
Thank you so much, Amanda. And is there anything else before we? Okay. I thank you all for joining us today. This was a great session. Thank Charlene, Carr, and Dr. Ehrlich today. It was great. And we will have this recorded, and you will be able to get it from our Maryland Living Well Center of Excellence website. So thank you so much.